Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Hello and welcome to this episode of the Long COVID podcast. I am absolutely delighted to be joined today by Dr. Tina Pearce, and we are going to be chatting a whole load around the mysterious topic of MCAS. So welcome to the podcast.
Thank you very much, Jackie, for inviting me.
So I'm absolutely loving having you here. To start with, would you mind introducing yourself just a little and explaining briefly what it is that you do?
Okay, so I qualified in 1983, an awfully long time ago, and I did GP training for 9 years and worked as a part-time GP for 7 years. And then I moved sideways and became a consultant in contraception and reproductive health. And I ran the contraception services for Surrey for 24 years, which I absolutely loved doing. So that took me to the end of my NHS career. I also became a menopause specialist within that time and was developing a private practice. And when I left the contraceptive services, I just concentrated on my menopause work and have a private practice in menopause. And I also have a daughter who in 2016 became very ill. So she had always been unwell and we never quite knew what was affecting her system and why she was so pale and had IBS and et cetera, et cetera. And then in 2016, she became super unwell. And I should think many of you have heard this story. And that was when I was forced to make a diagnosis in her, really, because no one was helping us. And I diagnosed histamine intolerance and then subsequently MCAS in her. And then we started the journey of making her better. And it's a long journey, and she's not cured by any stretch of the imagination, but she is much better than she was. And all the things that we discovered on the way have been incredibly helpful in helping me as a clinician. And once you learn something, you can't unlearn it, really, can you? And once I recognized it in her, I started recognizing it in so many patients that I was seeing, initially in 2016 for contraception. So when I was taking a full history from these patients, I would think, oh my goodness, they've got MCAS or they've got histamine intolerance. And I started treating and helping them. So it was about 6 or 7 people a week, I suppose, who I was sort of coincidentally stumbling across. And I did that for the next, from 2016 till now. And then I developed an interest in long COVID because when the COVID pandemic first started, I kept thinking and recognizing some of the pathology that was being described for the acute COVID as being MCAS type pathology. And therefore I felt I knew a new way of perhaps treating acute COVID. And lo and behold, now other practitioners have been treating it in the way that I started to treat it very successfully. And we believe that the hyperinflammation is MCAS in acute COVID. And then in August of 2020, I started hearing about the symptoms of long COVID and the existence of long COVID. And I recognized the symptoms as being MCAS type symptoms, really. And that's where my interest developed. And so I opened a long COVID clinic on the 1st of November 2020, it must have been. And then I organized a long COVID conference in June 2021. And my clinic is so busy, I've had to bring in another doctor, and I'm hoping to bring in a third doctor to help because we've got so many patients to try and help. So that's me in a nutshell, although I still do the menopause stuff.
Yeah, that sounds amazing.
The interesting thing for me is that women who come for the menopause often have some MCAS issues. And when they are given HRT, it doesn't sort of work in the way that it works with women who haven't got the MCAS issues. So they struggle trying to settle on HRT. And in my clinic, we recognize that they could have an histamine issue as well. And so we address both conditions. And unless you address both, you're not going to settle on the HRT. So that's another interesting dynamic, really, aspect of it. I see a lot of women who've been elsewhere for HRT and never quite settled or managed it, and actually feel worse sometimes on the HRT. And then when they come to see us, we sort out the fact that they've got some high histamine issues. And you have to deal with that as well as the lack of hormones that's going on at the perimenopause and postmenopausally, so that we can help them, improve their quality of life all round. And it's not right that women who have high histamine can't take HRT and should be denied the benefits and protection that HRT gives to women in their 50s, 60s, 70s, 80s, 90s.
Yeah, it sounds like there's quite a lot of things potentially in play there.
Yeah.
So, would you mind explaining just a little bit more about what MCAS is? Because, I'll admit, until Long COVID came along, I had never heard of it. And I think that's probably the case for quite a lot of other people.
Jackie, you are not alone. Most doctors haven't heard of it. And the reason is because it's quite a recently diagnosed, put together sort of syndrome, really. And the first cases were discussed in the 1980s. It was given a name in the 1990s. And then the three cases were published in 2007 in the medical journals. And that was the first time that this condition was described in the medical journals. So any doctors who didn't happen to read those presentations would not have heard of it, and it would have bypassed them. And most medical students, we get an hour at the most on mast cells, an hour lecture. And most of that's about allergies and mast cells, and a little bit about mastocytosis. And I remember being taught that mastocytosis was so rare that I would never see it in my whole medical career. The chances are I wouldn't see a case. And so, when you've got so much to learn and to get your head round, if you think, well, I'm not going to see that one, you sort of, put it to the back of your mind and don't really consider it. And then Mast Cell Activation Syndrome, as I say, is very recently described and presented to the medical profession. And so an awful lot of patients, poor things, have got this condition and have spent decades presenting themselves to their GP with various symptoms, all of which seem to be disparate and unrelated, and actually they're all often related. There is evidence of mast cell activation involvement, mast cell involvement in IBS, in fibromyalgia, in asthma, depression, ME, diabetes, obesity, atherosclerosis, psoriasis, rosacea, eczema, EDS, infertility, endometriosis, you name it, it's almost been, but certainly we've got evidence of mast cell involvement in those conditions, and POTS as well, chronic headaches and skin conditions, hives, rashes, dermatographism, and so on. And generally, patients are sent by their GPs to each of the specialties in isolation. So if they have IBS, they'll be sent to see a gastroenterologist. If they have POTS, they'll go and see a cardiologist. If they have skin problems, they'll go and see a dermatologist. And each of these consultants, if they didn't know about MCAS, would only concentrate on the symptoms to do with their modality, and they wouldn't see the patient as a whole and be thinking about what else was going on with them and could it be related. And so they would come back with usually completely normal tests, which of course is very reassuring. It means nothing else is going on that we could miss, and that's important because people with MCAS can also have other conditions and they need to be treated and excluded. But they wouldn't come back with any treatment or any idea of what was going on with them physically. And that is mentally very, very tough, and would mean that they often had a very low quality of life for many, many decades with not a clue. And they're sometimes made to feel like they were hypochondriacs, or they were moaning and they were always ill, but it was ill in their mind and so on. And actually it was really real, and it can be improved and sorted. It can't be cured. We've identified over 50 mutations in the KIT genes across all the KIT domains, which are to do with mast cell production, multiplication, and the way they work. And generally, we think people probably have multiple mutations in the KIT genes. And depending on their pattern of mutations, they will probably present in slightly different ways to each other. So it's complex, and there's very little research that's been done into it. So we absolutely need more research. We need improved diagnostic techniques. We need genomic sequencing of the mast cells to distinguish primary from secondary disease. Where is it being caused, where it's not genetic, but it's caused because of the way the mast cells have been aggravated by the environment. And also look at those different mutational patterns. We need to look at that so that we can see if they correlate with various different clinical presentations, which would be really helpful. And we also need to look at the biomarkers, the cytokines that they produce. Are we able to predict which cytokines are causing which symptoms, and how to therefore treat people and therefore get targeted therapies? So there's a lot of work to be done, and the etiology of MCAS is thought to be environmental, genetic, viral, and epigenetic. So it's not just genetic. So it can be just purely environmental and the response of the mast cells to the environment that a person finds themselves in. It can be viral, as in post-COVID, and it can be where there's non-genetic influences on gene expression, that's epigenetic. Yeah, so it's complicated, and a lot of doctors have not even heard about it. So they don't know to look for it. But the MCAS, we believe, has got about a 17% incidence in the population. So it's a lot of people. It's a lot of people. And if you think about how many people with IBS, with fibromyalgia, with chronic headaches, with urticaria, itchy skin issues, and so on, with rosacea, eczema, psoriasis, it's a lot of people. So you can see why 17.5% is probably about right.
Yeah, I mean, that's huge, isn't it? That's almost a fifth.
Yes, that's right. And there is a hypothesis that the patients who did very badly with COVID, the ones who ended up in ITU, etc., were often came from the MCAS pool of people because they had an abnormal immune response to the virus. And certainly that would seem to be correct, in as much that we know when we treat acute COVID, it can be treated with various vitamins and minerals that support the methylation cycles and the immune system, but also with antihistamines very effectively, because it's the mast cells that are producing the cytokine storm and causing this massive histamine release, this large histamine release that then causes inflammation and then hyperinflammation, which causes the great difficulties for many of the patients who end up in ITU. And that's not a normal response to infection. And those who have a robust immune system and normal mast cells, they would have the illness like any flu and get better, and their mast cells and everything would return to normal very quickly. Whereas patients with MCAS, that didn't happen. There was a study at Oxford University, and it was by Bergamaschi et al., and they looked at the response of people who had severe acute COVID and those who had mild acute COVID, and they've distinguished and said some people, their immune markers got back to normal very quickly and others didn't. And the ones who didn't are the ones who went on to get long COVID. And I believe that they didn't make the link of Mast Cell Activation Syndrome, but I believe that that's what they were showing in their paper. They also didn't know about Mast Cell Activation Syndrome, so they weren't looking to make that link. But that's what they stated in their sort of conclusion. Yeah, so there's an awful lot more to do and an awful lot more to learn, but there are things we can do and that we do know.
Yeah, that's really, really interesting. I mean, you were talking about the inflammation, and there's a lot of talk about inflammation being one of those things that kind of underpins a lot of the long COVID kind of symptoms and what causes it and things as well. So that plays into that too.
Yes, and if you think about where the mast cells are, what they are, if you imagine, is like they are the bouncers in a club. Okay, who stand at the door or just inside the doorway, all right? So anywhere that our body is exposed to the environment, so that's our nasal passages, our oropharynx, our lungs, our gut, our skin, the vagina, anywhere that's in contact with the environment really is full of mast cells. They are interstitial, so they're not floating around in the bloodstream. They are generally in the tissues, and they are around the nerves, they're around the lymphatics. And then when they are stimulated and they release this cytokine storm that everyone is now familiar with and has read about so many times with COVID, the cytokine storm creates the inflammation and also releases heparin, which increases bruising and increases bleeding. It also releases elastase 2, which causes membranes to break down. And all of these things, of course, are quite damaging to the body if they are long-term and become chronic. They're supposed to be part of the natural immune response to acute infection, but they're supposed to go very quickly. But in patients with MCAS, those mast cells just keep producing those cytokines and they keep going with it, and they don't know when to stop, basically. So that prolongs all the symptoms and gets into this vicious cycle of inflammation. And, if it's affecting your nerves, then I think that's what causes this fizzy feeling that people talk about, vibrations in their bodies and things. I think that's where the mast cells are around their nerves and are aggravated by the COVID and so on. So you can sort of, when you start to understand a little bit of it, you can sort of see what's happening in the body. And when the gut is affected, we are learning more and more about that, and the microbiome seems to be affected. And there are a couple of papers recently, they looked at whether COVID was present, and they found COVID present in the stools. And they think in the long COVID patients, maybe COVID is still multiplying up in the gut. And therefore, we're now starting to think maybe what we should be doing is clearing the gut with some antibiotics. And they actually proved which antibiotics worked in this study, which is very interesting. So it was metronidazole, which is not a nice antibiotic, vancomycin, amoxicillin, a couple of others, which I can't remember. But there are some natural remedies that one can take, which would be worth trying first. So that's another aspect that we need to look at, because maybe I feel with my long COVID patient, there's something keeping it going. We're doing all the right treatments for MCAS, but they're still unwell. They might get a bit better, but not completely better, and they relapse. And it feels like there's still something pressing the buttons and keeping it going. I've identified a few interesting stimuli, and your listeners may be very interested in this, and mold is one that they must look for. So mold, if you've been ever been exposed to mold in your house, where you've stayed, whatever, you must think about treating mycotoxins in your body. And there are some various tests one can do to look for them. There's a urine test, which is the Great Plains mycotoxin test that can be done online off the internet. Some doctors say, you need to do a blood test, but actually in the UK, it's very difficult to get the antibody for the mycotoxins done here. So we might have to rely on the urine. But it's very important to treat those. It also seems to be the COVID virus seems to reactivate Epstein-Barr virus, the glandular fever virus. So again, one needs to check that with your doctors. Has that been reactivated? You need to have treatment for that fairly long term. Lyme's disease as well is another one that it seems to reactivate. And if we don't eliminate those, we're never going to sort of get people better. And now I'm starting to look at the possibility of the COVID still being in the guts and how we should treat that, really, if somebody has lots of gastric symptoms, But it's a complicated picture.
Yeah, it definitely is. And what you're just saying about, the people getting a bit better, but there still being something, it's almost like we're missing a tiny piece of the puzzle, isn't it?
Yes, it does feel like that. And there are certain things that I do in my clinic to try and look at all aspects of this and the person holistically. So we look at their genes and get a lot of very helpful information from their genetic profile to do with their methylation cycles, their histamine metabolism, especially, and their estrogen metabolism, because all of those feed into each other, so that's important to look at. And then support the body with vitamins and minerals where they are cofactors for poorly performing genes in those pathways. So if you identify that somebody has got very poor histamine metabolism, for example, then you know that going on a low histamine diet is going to be very helpful for them. and antihistamines should be very helpful for them as well. So we look at the genes, we look at the microbiome of the gut, and that has been often very disrupted. Now, whether it was disrupted prior to COVID or it's disrupted by COVID, often it's worse with COVID, but by no means are all these patients perfect specimens when it comes to their gut before, So we look at the balance of the bacteria, the biomarkers, the inflammatory markers, the immune system markers, and try and get that much better into balance, much better balance for all of that, giving the right probiotics, boosting the immune system through the gut, where most of our immune system is actually 70% of our immunity is in our gut. So we look at that. We look at the psychological aspects as well, and neuroplastic retraining, which I know can be quite controversial, but neuroplastic retraining, all I can say is that there are plenty of studies to show that it works in various different medical conditions, and that we do have plasticity of the brain and we can retrain our brains. And all of my patients who have done something like the Gupta program, neuroplastic retraining, have found it to be very helpful. That's 30%, some have said 30% improvement by doing that program. So I think it's worth people considering. Oh yes, I must tell you about my new device that I've been using and patients have been using, which really is worth trying. And this is an ARC microtech device, and it produces a microcurrent, Jackie. What it does, first of all, is it assesses what your own natural current is, your frequency. It goes through 4.5 million frequencies, and it detects which one is your particular individual frequency, and then it tunes into that, and it gives you a microcurrent in the correct frequency for 3 hours, and after 3 hours it switches itself off. You wear it around your arm for 3 hours a day for 6 weeks, going through there are 4 different programs, and you go through the programs. And then after that, you have to use it 2, 3, 4 times a week only. And every 6 months, you should do the 6-week block again to sort of reset everything. And what it does is it boosts ATP in all the cells, which is fascinating, because the ATP is made in your mitochondria of every single cell in the body. And that's the energy source, the power that the cell runs on. And the efficiency and the functionality of the cell is going to be determined by how much ATP it has. So obviously we want all of our cells to be all singing and all dancing all the time. And if their ATP becomes depleted, then they're not, and they can malfunction or misfunction or just stop functioning. And by boosting the ATP, we promote healing and reduce inflammation, which is the big thing that we're all fighting. So I have been trying it myself because I have MCAS, and I have found it to be really, really good. And I have lots of patients trying it. And I would say 95% of them say there's been an improvement. And the improvements have been very interesting. Some have had reduced pain, some have had reduced headaches, some have had better sleep, some have had improvement in their brain function, feeling more relaxed, so less brain fog, less fatigue. And some have had all of those things, an improvement in every single little area, which has been very helpful. So I would recommend it to people. There is a code which will give them £20 off if they want to order it. I don't know if you want to put that into your information.
If you're happy, I can put that in the show notes.
Yeah, no. I'm very happy because, I want people to be able to try anything and everything that they want to. And it's all very expensive. Everything is expensive. All the vitamins and minerals, doing everything is expensive, isn't it? Yeah, so it was developed, actually. It was very interesting. It was developed for racehorses. And they found that if racehorses obviously are injured, it's very expensive to have a racehorse not racing. And they wanted to heal them up as quickly as possible. And so this kind of device was developed for that. And the horses improved more quickly. And then the jockeys were so impressed, they started wearing them as well when they were injured. And then they asked the company to make one that was more mobile and easier for a human to wear. And that's what they did. And now a lot of long COVID patients and a lot of MCAS patients and patients with ME, CFS are all using it and finding it helpful. So worth a try. Yeah.
That's fascinating. Yeah, thank you for that. I will put that in the show notes along with a link where people can go and have a look at it. So if anyone's interested. We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us.
The other treatments that I've been doing, Jackie, for your listeners, is usually I ask people to go on a I always ask them to go on a low histamine diet, and some of them say within 3 days they start to feel better. Yeah. It can be very dramatic, and I follow the Swiss histamine interest group, the SIGI group list of histamine foods, because there are some contradictory lists on the internet, and I think the important thing is just try and get one that seems to be medically sanctioned, and I know the SIGI one is, and then try and stick to it. And you can get apps on your phone which help with shopping and things and making choices when you're going out to eat and stuff. So having a low histamine diet is sort of first mainstay. The second thing then is to try antihistamines, type 1 and type 2. And not everybody responds to both, but most people do respond to both. And so I would say the principle is try one thing at a time, or introduce one thing at a time, and do it slowly. So maybe you start with over-the-counter loratadine, 10 milligrams. Try it. If you tolerate it, take it once in the day. The next day, take it twice. So you take it 12 hourly. And the next day, you could take it 3 times a day. And do that for a couple of weeks, up to a month, and see if you feel it's helping. And if it's helping, then you keep it. If after 2 weeks of being on it, you feel it's not helping, then don't stay on it for a month, change it to another one, and try cetirizine 10 milligrams, again, in the same kind of way, and see which one of those seems better. And then if it doesn't seem to help after 2 weeks, go to fexofenadine. Now you can buy 120 milligrams of fexofenadine over the counter. The strongest is 180, which requires a prescription. So if your GP would give you some, that would be great, but if not, buy some and see which of the 3 is the most effective. Now, if the first one you try is brilliant, just stick with it. Okay. And then after a couple of weeks, when you think, yes, this is definitely helping, then add a type 2 antihistamine. Unfortunately, we can't buy those over the counter in this country. So you rely on a prescription, and that would be famotidine or nizatidine. They're the 2. Famotidine is stronger, and you take 20 milligrams twice a day. And if it seems to be helping, try 40 milligrams twice a day and see if that's even better. If it isn't, go back to the 20s, but if it is, then that's great. So now you've got your type 1, you've added maybe a type 2, and then we like to use a mast cell stabilizer such as ketotifen or rupatadine. If somebody has a lot of gut issues, especially if they're tender in the epigastrium, that's the upper part of the bowel, the transverse colon goes across the top of your stomach, under your ribs. If you're tender there, that can be a sign that you've got mast cell aggregation in that area of your gut, in the gut wall, in which case sodium chromoglycate, which is a very effective mast cell stabilizer for the gut, can be taken. And that usually can be very helpful. Then there's also low-dose naltrexone, which is a good mast cell stabilizer and reduces the impact of the cytokines that are being released. And we've also got montelukast, 10 milligrams a day, which is a leukotriene inhibitor, and that's one of the cytokines that's released by the mast cells. You have to watch out with montelukast. About 30% of the patients get depression on that. So you want to just be mindful of that. If you start to feel low and flat, please stop taking it. Diazepam can be very helpful. Patients who have MCAS who go on diazepam don't become addicted to it, interestingly enough. It inhibits the mediator release from the mast cells, and it sits on the mast cells and blocks them from being activated. And if it's sitting on the mast cells, it can't sit in your brain and cause addiction. So people who take diazepam who have MCAS can stop taking it just like that. There's no withdrawal symptoms or anything, and there's no addiction to it. But they don't need a very big dose. They can just have a small dose, like 0.5 milligrams twice a day, maybe 1 milligram twice a day. Yeah, so we walk through all of those, and then there are a few other things which are quite specialist medications like colchicine and some other sort of immunosuppressant type drugs. But generally, on the basic initial drugs that I talked about, people can find improvement and respite. We have to treat the EBV, we have to treat the mold, we have to treat any other infections, so urinary tract infections, eye infections, toenail infections, anything like that must get treated, because any infection will stimulate your mast cells and keep stimulating them. And now we need to look at the gut and see whether we need to be treating people as if they still have COVID being produced in their gut.
Yeah, and that's really interesting what you say about the virus in the gut, because does that tap into this idea of viral persistence?
Yes, exactly that. So that's the next area we need to explore, I think. It's been a very interesting journey. It's been incredibly rewarding work, I must say, because patients, some of them get better almost immediately, and within a few weeks they get better, and others it's slower, but there is an improvement. We're going in the right direction, and so the quality of life improves. And I've got loads of patients who've been able to go back to work, who've been able to look after their children again, etc. And that's just so rewarding, really gratifying to see that happening, and alarming that the NHS isn't really managing these patients and helping them in a way that they should be. I know a lot of long COVID clinics were opened across the country, but for many months they did nothing apart from refer people to various different consultants. I suppose that's not nothing, that's not fair. But, people had a lot of investigations and they were reassured that they had nothing serious and sinister wrong with them, but they weren't given any idea as to what really was going on or how to treat it. And I don't know whether the long COVID clinics are still open in the NHS. Are they still going?
I think it's very different in different places. I mean, I'm in Scotland where we don't have long COVID clinics at all. And I think in England there are quite a few, but it's very different area to area from what I've heard.
Yeah. And I think sometimes, patients go and initially they were tested for various things, which is all well and good, but not given any treatment. And then they were told to rest and do breathing exercises, which is a shame, because that was after my conference when I had quite clearly had speakers talking about the various treatments that we were finding helpful and effective. And the conference is still available actually online. It's treatlongcovid.com, and anyone can see the lectures. They're all still there. And there's an excellent lecture by Dr. Lawrence Afrin, who is the MCAS guru globally. And if anyone wants to watch a really brilliant lecture on MCAS to understand it and drill down with it, then I would recommend that they have a look at that. My goal of having the conference was to really actually put MCAS on the map. And I was so delighted when he said he would come and do a presentation. It was like, yes, we had 2,200 people register for the conference, which is great. And I do feel that, and I don't know if I'm disillusioning myself here, but I do feel that since then, because patients have learnt and heard about MCAS, they are educating their doctors about it. And so some of the doctors now seem to know more about it. So some of the gastroenterologists are recognizing it, some of the dermatologists are recognizing it, some of the immunologists, even some of the immunologists are recognizing it. Although there are still a few who don't believe it exists, which is a shame, because people respond to the treatment, so that's interesting. But yeah, so I've been really gratified by the fact that over the last 6 months, as a result of podcasts like yours and various other ones that I've done, people globally are starting to talk about it more. And that's really brilliant, absolutely brilliant, because that's what we need to do. And then hopefully there'll be more research and there'll be more money put behind it, and then we'll come up with some more treatments for people.
Yeah, exactly. I mean, what you were saying about the patients talking about it and educating their doctors, there seems to be quite a lot of that, I guess, because we're sitting around just being ill and wanting nothing more than to get better. And I've certainly noticed a lot of people talking about, they've been forced into doing their own research and taking research papers to their GPs.
Yes.
And some GPs have been very receptive to this, but there have also been some that haven't. And that's been, I think, a source of a lot of frustration for people.
Very challenging, very challenging. Yeah. And some have been fantastic and are very interested to learn about it. And when you consider that 17% of their patients will have it, and that they are probably seeing it every single day, several times a day, with patients coming with IBS, fibromyalgia, rosacea, et cetera, then I'm really hopeful that things are going to improve for everybody, not just the long COVID patients. I suppose, the silver lining of all of that is that it's shone a big light onto this condition, and hopefully we will improve treatments and our understanding more and more as the years go by, which would be fantastic. The other treatments that patients try, and I'm sure your listeners are fully aware of all of these because they've probably tried them all, is hyperbaric oxygen, apheresis, which is blood clots, going and having it cleared. There are a couple of clinics in Germany and in Cyprus, I believe, who are doing this. But I must say, my patients who've gone to do that, they haven't come back and told me that they are very much better, which is a shame. They might feel better for a few days, but then it catches up with them again. And whether that's because they've actually got it in their gut still, it's an interesting one, isn't it? And ozone, apparently, which increases the oxygen in the cells, that's been helpful. And there's a clinic in Surbiton that do it. There may be others that do ozone, that give you intravenous ozone, or up your bottom, actually. The other way you can have it. So yes, there we are. That's a whistle-stop tour. The tests for MCAS are really difficult. The diagnostics that we have are very limited, and we can measure serum tryptase. But in allergic reactions, allergic disease, serum tryptase is normal. In mastocytosis, it is elevated. And in Mast Cell Activation Syndrome, it is normal. So it doesn't really tell us that much. I suppose the only thing it does do is it eliminates mastocytosis as a diagnosis. And that's important because mastocytosis is much more serious and has more implications for future health than MCAS does. So important to eliminate it and do our due diligence to do that, but it doesn't actually help us with the MCAS diagnosis. The other things that can be done, which are not easy in the UK, are you can look at the serum chromogranin A, but you must avoid PPIs for 5 days before having this test. Okay, so PPIs are often prescribed for reflux and hyperacidity in the stomach. They must be stopped for 5 days before doing chromogranin A. But then the other tests need to be on chilled serum, chilled plasma, prostaglandin D2, histamine, and heparin. And we don't have laboratories that can do that. So that's a shame. And there's also chilled urine, 24-hour urine has to be collected and kept chilled. So in the fridge. And that can look for prostaglandin D2 and N-methylhistamine. But if it becomes less than chilled at any point in the chain, it is null and void. Also, you can look for leukotrienes in chilled urine. You can look for various leukotrienes. But again, as soon as the temperature rises even a little bit, it becomes lukewarm, you're done. You're done, you can't have that. And our laboratories just aren't able to do that, unfortunately. So not easy. There's a couple of companies I'm looking into who are starting to do some cytokine reports on one single sample of blood. And I'm really quite interested in looking at those and seeing what they would reveal in my patients, So that's an avenue we're exploring at the moment.
That's fascinating, isn't it? But yeah, logistically, not particularly easy.
Not easy and, expensive. A lot of these things are expensive. And when you bear in mind, a lot of the poor patients who have long COVID aren't able to work because of their condition, it's like a double whammy for them, isn't it? It's like, oh dear, I'm asking you to have all these tests done and they're jolly expensive. And it's heartbreaking, really.
Yes, yeah, absolutely. It's difficult. People on benefits or not benefits, depending on whether they can get them and not able to work. And the stress and the strain is not helping recovery in itself, that's for sure.
No, I'm sure. I think, if one approaches it and tackles it in doing meditation, doing the low histamine diet, drinking filtered water, actually, even just that. And you can buy these charcoal sticks and put them in your water jug. And they're very reasonably priced, like £12 a stick, and they will last 6 months. So patients who I've recommended that to have said, do you know what? I feel better for drinking the water from the jug. Just eliminating some of but that's a much cheaper way of doing it than buying mineral water or whatever. And also we should only be drinking from glass bottles and things. So we want to eliminate plastic, processed foods. As much sort of chemical stimulation as possible needs to be removed from the environment, including switching your Wi-Fi off at night and not having a phone in your bedroom and all this sort of thing, because that also is stimulating your mast cells.
We'll be right back. Hey there, I'm just jumping in for a second to see if you're enjoying this episode. If you're finding it useful, maybe you would consider sharing it somewhere, a friend, a group, or even on your Twitter feed. If everyone was able to share just once, we'd be able to get this information out to even more people who really, really need it. So please consider sharing somewhere if you possibly can. I hope you enjoy the episode, and thank you so much. Yeah, that's interesting. I mean, there's a load of things that you've mentioned. So I'm sure even if some of them are difficult for people to try, there's enough there that hopefully everyone can find something that might, I guess it might give them an idea of whether it is going to help, I guess.
Yes, if they can get their GPs to prescribe some of the medication, that would be really helpful. Obviously, you want to go through your GP if at all possible, because things like sodium chromoglycate is expensive, rupatadine is expensive. It's tragic. They used to be very, very cheap. For some reason, they've become expensive. I think it's called profiteering. The other thing I've seen is some of my patients are getting long COVID from the vaccine. So they were absolutely fine before, and then they had the vaccine and they get long COVID. So I am very cautious about that.
Yes. And do we think that's a similar sort of trigger, I suppose is maybe the word, to the COVID itself?
Yeah, absolutely. Because when you think about what the messenger RNA is doing in the vaccine, it enters our cells. So it doesn't stay in the deltoid muscle. It goes around the body. It concentrates in the ovaries, the testicles, the liver, the heart, the brain, and the spleen. And it goes into the lymphatics, the lymph nodes. And it enters previously healthy cells. And it sets up a little factory making, from the messenger RNA, making the spike protein, which is the pathogen. That's the worst bit of the COVID. So it's not a surprise that some people's mast cells are going to respond to that as if they have had COVID, and that will give them long COVID. So quite a number of my patients, that is the case, that they were fine until they had the jab. And then the previously healthy cells that are entered by the messenger RNA, your body then identifies as cells which contain a virus and it destroys them. So that's a bit of autoimmune disease going on where we're destroying our own cells, and that's not great either.
Yes, because of course autoimmune, that's another sort of prong of long COVID, isn't it, that a lot of people are talking about. So do you think that everybody with long COVID has underlying mast cell sort of, is issues the right word? I'm not sure. Do you think it's in everybody?
It's a good question. I would say, in my experience, looking at this, not just their symptoms, but at their histories, 98% of my patients, that's the case. They had previously undiagnosed, untreated, unrecognized mast cell activation syndrome going on to one degree or another. And therefore, what has happened is typical in an MCAS patient. When you get a viral infection, it presses all the buttons to increase the MCAS. And that's what post-viral fatigue is, I think, and ME and so on, post-viral ME, chronic fatigue syndrome. So COVID is no different to any other virus for doing that to patients with MCAS. And I would say I've only had a couple of patients in whom there was no previous history, none whatsoever. And interestingly enough, those patients responded incredibly quickly to the treatment and got better within 2 weeks. having been ill with long COVID for months. When they went on to a low histamine diet and they took the antihistamines and they had a mast cell stabilizer, 2 weeks, 3 weeks later, they were better. They were better. So for them, it was easier it switched on, and it was much easier to switch it off. But for the vast majority of my patients, 98% of them, that's not the case, because they've got a previous history, a predisposition, if you like, to mast cells that are super activated by COVID. We know that COVID passes through into the mast cells very easily through the ACE2 receptors, and it seems to do that, excellently. And then it sets everything off. So I think it's been a sort of super stimulant when it comes to MCAS, really.
Of course, yeah, that's fascinating. See, I don't know if it is related, and I'm sure you'll be able to tell me, but people who get, other allergies, hay fever, for example, and hay fever is very related to histamine, isn't it? So do people who get hay fever, do they have MCAS, or is it related, or?
Yeah, so mast cell activation disease, MCAD, includes allergies, mastocytosis, and MCAS. So the allergic diseases have inflammation and allergy type reactions to things, and they are a mast cell activation disease. So that's why some people get hay fever and other people don't, because some people's mast cells respond in that way to pollen and others don't. But mast cell activation syndrome is a subset, if you like, of the MCAD, and that is inflammation, allergy, and dystrophism. So people who have MCAS can have inflammation, allergy type symptoms, and also dystrophism, which is abnormal mounds of cells. They can have like benign tumors almost as well. Sometimes and I've seen this in my patients. I had one lady I diagnosed on the plane, actually. I sat next to her on the plane coming back from Italy, I think it was, and she was very sweet. We started chatting, and she told me about all these symptoms she was having, because when people know you're a doctor, they just do that, no matter where you are. You could be at a party and they'll do it. It's sort of irresistible, and I know it's going to happen. So anyway, I suppose it's up to me not to say I'm a doctor, but when somebody asks me what I do, I can't lie. So anyway, so she started telling me all her symptoms, and I said, I think it sounds like you've got mast cell activation syndrome. And then she said, look, I've got this mass here on and it was in her sort of clavicle area. She said, I've got this mass here and they're going to biopsy it. And, and I said to her, and it was like a fatty lump. And I said, I'm sure that'll be your mast cells. That'll be a mast cell aggregation. Ask them to stain it with CD117. It's a special stain that shows up the mast cells. So I was asking her to do this. Anyway, bless her heart, she took my number and she texted me a few weeks later, and she had gone on a low histamine diet. She'd started some antihistamines and so on. And she was so jubilant because she was so much better. She was feeling so much better. I don't know the result of her biopsy, but yes. And I had another patient who had like a swollen ankle, and when we got her mast cells under control, it dissolved, it calmed down. And I say dissolved, it reduced in size and went. I'm sure the mast cells were still sitting there, but they weren't so inflamed and big. And I had another patient who had like a lipoma under her skin. And I said to her, I think this could be a group of mast cells aggregating. And she, when she went on the antihistamines, that went away as well. So it wasn't a lipoma, because they don't disappear. So very, very interesting. Yeah.
Yeah, it's fascinating, isn't it? And how people with long COVID have been saying, I think since the start, that, COVID was supposed to be a respiratory virus, but, this is affecting my whole body. Why am I getting symptoms in my head and symptoms in my gut and symptoms, all over the shop? And this could explain it, because these mast cells are everywhere.
They are everywhere. Yes, they are. They are absolutely everywhere. And, they have a very important role to play in our immune systems, and it release acid in our stomach, and they are very essential. Histamine releases acid in the stomach as produced by the mast cells, and histamine also is a neurotransmitter as produced by the mast cells. So it's got some really important functions. It helps with our circadian rhythm. Helps us to sleep the right amount of time, etc., and to feel sleepy at night and not during the day and stuff. But these poor patients who have too much histamine, they find they have terrible insomnia. They can't sleep because it completely puts out their circadian rhythm, which is normally responsible for and has to be in the right balance to do that. so it has some very important functions, but it just, when it's out of kilter, it's like poison, and it feels like you're being poisoned because you basically are by your own chemicals. And interestingly enough, that's why also I believe so many of the tests are normal. When people check their lung function test, they check this, they check that, and it's all normal, but the patient doesn't feel normal at all.
I guess it's a case of everything in moderation, isn't it? Histamines, chocolate, depending on...
Yeah, cytokines, yeah. But yes, the body knows what it's doing normally, but it's gone a bit awry.
Yes, it is. It's just like everything's just slightly out of kilter and it's struggling to get back into alignment, isn't it?
When people can, they should also have organic food, as much as possible, no processed food, get out in the fresh air, get back to nature, boost their immune system. There's an excellent website for helping people and getting information about COVID, actually, and it's worldcouncilforhealth.org. And it gives unbiased, uncensored information about COVID and about how to boost your immune system, how to stay healthy, how to treat acute COVID, and so on. So really a useful website for every family.
So all those links that you've mentioned, I'll put them all in the show notes. So if there are people that want to go and check those out, then that should hopefully make it easy for them to find.
Brilliant, Jackie.
Well, thank you so much for joining me today. It's been an absolute pleasure chatting to you, and I'm sure a lot of what you have said will be really, really helpful to so many with long COVID. So thank you so much.
If it helps get the word out about MCAS and treatments, then fantastic. So thank you.
Thank you so much to all of my guests, and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch. I'd love to hear from you.